Okay, class, we're going to go on to determining if someone is a diabetic and how we make that diagnosis. First of all, we do the all-important assessment. We definitely look at their history, let them kind of give us a feel or give the healthcare provider of what's been going on in their life in regards to their diet, urination, their weight. We look at their age. Are they in that age where they would be more susceptible to acquiring type 2 diabetes? We look at their weight. We look at the weight of the children, especially with female patients. How big were your babies when you delivered them? Were they over 9 pounds? Do you experience a lot of fatigue? Do you experience polyuria, polydipsia? What about healing? When you get an injury or a cut, how well do you heal? And what are your recent infections? Remember, diabetes is much more common in older adults, and obviously we look specifically at women who have those very, very large babies, or even women who during their pregnancy develop gestational diabetes. Those women are much more prone to developing diabetes later on in their life. And we look at weight. Obesity is a big factor because remember, if we go back to type 2 diabetics, the big hallmark manifestation is the insulin resistance that occurs, and that increases the larger and the heavier a person is. And of course, definitely look at infections, okay, because those people with high blood glucose and hyperglycemia will have more infections, and of course the healing process really starts to decrease as that blood glucose continues to rise, okay? You might also see women who begin to develop diabetes have more frequent vaginal yeast infections, and people may start to kind of realize that they have noticeable changes in their vision and even when they touch. And this is obviously a sign of neuropathy starting to occur. So let's look at how we diagnose a person with diabetes, because this is a fairly very significant diagnosis, especially with such a overwhelming chronic disease that obviously has really taken our communities and even our country by storm, because it is absolutely on the uprise. First of all, one of the simplest ways in which we can diagnose diabetes is by a fasting plasma glucose, okay? Very simple. Probably one of the least inexpensive ways in which we can draw blood and determine if a person is a diabetic. It's usually the preferred test to diagnose diabetes in, remember, a non-pregnant adult. The only thing that's necessary to do before the test as far as prep work is to make sure the person has no caloric intake for at least 8 hours. Water is permitted. And then if by some chance they're already diagnosed and have been on medication such as insulin, we would obtain that sample before insulin or before any oral anti-diabetic agent. And we don't just go by one sample. It's important that we make that diagnosis with 2 different separate test results. And I'll give you the parameters in which we would make that diagnosis with, okay? we kind of look at the results in two ways. We look at, obviously, the results of this test, the fasting blood sugar, and look for what we call either an impaired fasting glucose or actually making the diagnosis of diabetes. And normally, your fasting plasma glucose should be under 100 milligrams per deciliter, okay? Usually levels rise 1 milligram per deciliter per decade of age. And so you might see that somebody might have 104, 103 milligrams per deciliter blood sugar result. And that's what we sometimes see with the aging patient, depending on how old they are. But for an impaired fasting blood glucose, and these are those population of people that are pre-diabetic, okay? Usually that results comes back as under 126 milligrams per deciliters, okay? And so to make that diabetes diagnosis, you would have to obtain 2 occasions of testing where the levels are over 126. So that's pretty simple to kind of understand, okay? And remember, it would be good to be able to catch these people who have that range between 100 and 126. You know, they're a little bit elevated, but not quite in that zone of over 126 milligrams per deciliter. So we'd want to, get these people on board with some good teaching, maybe changing lifestyles, getting them to lose weight, so they wouldn't start to fall into that diabetic diagnosis. This is where they're becoming somewhat insulin resistant. That's why their blood glucoses are up somewhat, but not actually in that range where we would definitely make that diagnosis. So again, we're looking at this first test called the fasting plasma glucose, an FPG, where obviously the most common, probably the most economical type of test in a non-pregnant adult, in which all that is necessary as far as prep is that the person has no caloric intake for at least 8 hours, but water is permitted. And as we said before, that normal blood glucose range is about 100 or less, and with our patients having a fasting plasma glucose, 100 to under 126 milligrams per deciliter is considered an impaired fasting glucose, not necessarily you're diabetic, but you're getting close. You're probably what we consider a pre-diabetic, but anything over 126 milligrams per deciliter would be considered diabetes. And this has to be done with 2 samples on 2 different occasions, okay? So that's very important. We just don't take the first result and say, oh, you're diabetic. No, we'd like to get a second sample to confirm that diagnosis of diabetes, okay? The next one is an oral glucose tolerance test, and OGTT, and it's probably the most sensitive. This one is mainly used in pregnancy, so many of you ladies out there who have had pregnancies may have had this done. Patients need to fast about 10 to 12 hours prior to testing. Test takes place in the morning, and what is required of you is that you drink about 300 milliliters of a glucose beverage containing about 75 grams of sugar, and this must be taken within about 5 minutes. And then they do 2-hour testing. They'll take the patient's blood glucose levels every hour, and we recommend too that to get a list of the medications the patient is on, and they are not to take any medications like Dilantin, diuretics, glucocorticoids, and birth control pills until testing is completed, because they can actually interfere with the test results. So this is what we called a oral glucose tolerance test, and how we interpret these findings are normally it would be under 140 milligrams per deciliter, and when we talk about an impaired glucose tolerance test results, that would be any result within 140 to less than 200 milligrams per deciliter, and any level or results over 200 would indicate provisional diagnostic diagnosis of diabetes. So that's what we called an OGTT, an oral glucose tolerance test. But there are those necessary provisions that we want to make sure that patients follow before they come in. This is a little bit more of an expensive test, so we want to really get it right the first time. So they really should eat a balanced diet with some carbohydrate intake, at least 150 grams for a minimum of 3 days with normal activity. If they are on a carbohydrate restriction or bed rest or acute illness, it can actually interfere with the test results. And as I said, they'll drink a certain amount of fluids that contain a high percentage of sugar, and then they'll take blood samples every 30 minutes in intervals for 2 hours. And during this time, as they're drawing these samples, we really ask that the person remain at rest and they're not able to smoke or drink any kind of liquids, just to give us a very realistic and reliable test results. Okay, and again, the results, usually we see blood glucoses under 140 milligrams per deciliter. That would be normal. Abnormal or impaired would be 140, greater but less than 200, and a diagnosis of diabetes would be over 200. Okay, so that is what we call a OGTT. They don't do those routinely most of the time. We can make that diagnosis with a fasting blood sugar, as I talked about previously. Other blood tests for diabetes. Now, this isn't actually a test that we do to make that diagnosis. It's an hemoglobin A1C, and this indicates how much sugar has been in a person's blood during the past 2 to 4 months. It monitors the effectiveness of diabetes treatment. So it really looks at, do we have you on the right medications? Are you eating the right diet? Are we getting that blood glucose under fairly good control? Glycosylated hemoglobin measures the percentage of hemoglobin that's bound to glucose. And as hemoglobin and glucose are together in the red blood cells, the glucose gradually binds to the A1C form of hemoglobin in a process called glycosylation. And this amount reflects how much glucose has been in the blood during the past average 120 days. Pretty much the lifespan of a red blood cell, okay? Non-diabetic should be between about 4 to 6%, and we like to keep diabetics under 7%, okay? And the good thing about hemoglobin A1C is the fact that the results are not altered by eating habits the day before the test. This is not something that we do every week, once a month. It's really done at least twice yearly, and maybe increased to quarterly assessments for a person whose therapy has been changed, or really who really is not getting those glucose levels within a stable and acceptable range. So that's why we might be doing those a little bit more frequently on some people. Okay? And then obviously another type of test is urine testing, where they can look at ketone bodies, the product of fat metabolism. The presence of moderate to high urine ketones indicates a severe lack of insulin, okay? And these are considered not acceptable, and it really indicates and kind of portrays that the person really doesn't have good glucose control. So you wouldn't want somebody to be out, exercising, and if they were ill, this would be an indication that maybe they need to seek medical attention, because this could further lead to some serious diabetic emergencies like DKA or things like that. And urine testing for these ketones should be performed during acute illness or stress, when blood glucose levels consistently exceed 300 milligrams during pregnancy, because this could be a sign of ketoacidosis, leading that patient to go into what we call a diabetic ketoacidosis state. So that's why, again, not only blood sampling testing, but also testing urine for ketones, especially if they notice that their Accu-Checks at home are consistently over 300. That's obviously not good control, and there's something going on there. Either they're not on the right medications, there could be a stressor in their life, could be due to medications, could be due to the fact that they're, not on the correct amount of insulin, maybe their diet is off. So there's a lot of things that could be the reason why these blood glucose continuously exceed 300 and that the person is spilling ketones in the urine. If a person is on some type of weight loss problem, that's another reason that we would really want to check for these ketones. Hyperketonuria and hyperglycemia suggest that weight loss is occurring without disrupting blood glucose control. And along with many of these urine testing, we're also going to test kidney function for microalbuminuria. Remember, we talked about that earlier, where if proteins are going through that glomerulus and being excreted through the urine, this is not a good sign. And remember, urine glucose can be affected by many things, such as fluids, urine elimination, and patterns of certain drugs. So there's a lot of things to consider, okay, before we, get alarmed. So we kind of look at the whole situation with our patients, and definitely looking at, the medications that they are on. Because I told you there are so many factors that really do influence our blood glucose, okay. Other blood tests that may be done, these are not as common or as popular that you might be familiar with, or they can do, especially for type 1 diabetics, they can do islet cell antibodies, and that is an indicator for type 1. And remember, type 1 is an autoimmune disease with the presence of autoantibodies to proteins. And measurement of C-peptide levels indicates beta secretory function of the pancreas, and C-peptide levels can correlate well with insulin levels used to diagnose type 1. So these are specific ways in which we can really determine that the reason the patient is manifesting these symptoms is actually due to the fact that they have type 1 diabetes. Again, continuous screening of people, especially over 45 years of age, people that are overweight. We can use either the fasting plasma glucose or either the OGTT test. Okay, so that's quite important. All right. We've talked about just making sure that people at a certain age are being tested for the possibility of either prediabetes or diabetes, especially if you have many of the risk factors. If you have a first-degree relative with diabetes, if you're fairly an inactive person, and also that high ethnic population such as African Americans, Hispanic, American Indian, and Asian. Women who deliver a baby of 9 pounds, or even develop gestational diabetes, people with hypertension, especially systolic over 140, over 90 diastolic, if their HDLs are low, if their triglycerides are high, preferably over 250, and if they've had any history of polycystic ovary disease, or maybe in the past have had some kind of impaired fasting glucose of 126 over 126 or below 200, or an impaired glucose tolerance test between 140 and less than 200. So those are things that you might want to consider when you're looking at the history, or maybe doing some teaching with people who might be a candidate of developing type 2 diabetes. Okay. Just want to draw your attention to the term casual blood sugar. That's a blood sugar any time of the day without regard to time since last meal, usually greater than 200. Okay, so sometimes when we see that happen, that could be an indication that a person may be developing diabetes. Okay. So I'd really recommend just kind of thinking in your mind, looking at basically the two most important blood tests that we do to make that diagnosis. And the fasting blood glucose or fasting plasma glucose, which are the same thing, probably is the most common and the most economical in regards to making that diagnosis of diabetes. And then the other one is the OGTT. You do have to think in your mind what determines prediabetes versus a true diagnosis of diabetes. And these other blood tests are a little bit insignificant and less common, but they can be done to really make that substantial diagnosis of a type 1 diabetes. But remember, anytime ketones are in the urine, particularly when they're at a moderate or high level, that's not a good thing. That indicates that the patient is not well controlled. And we usually see that when patients' blood glucoses are probably well over 250, 300. You know, so when your patients tell you as you administer medications, or let them know what their blood glucose is, because many times your patients will ask, okay, what's my blood sugar running today? And they say, oh, and you tell them, oh, it's about 250, 300. They'll say, oh, that's good for me. Tell them that's not good for any diabetic. That is too high of a blood glucose. And these people are probably spilling over ketones. And this is a very serious situation, because with any additional stressor in their life, this really puts them at risk for developing these emergencies like DKA. And because they're very ketotic right now, a lot of ketosis is going on. So this is not a good situation for them to be on, and it really shows that they have poor glucose control. And this is where we have to intervene and get that teaching done so they understand that, yes, if that's what you've been running, that is not a good blood sugar. You know, we want to get those blood glucoses low, okay? Because, you know, think about all those later on macro and microvascular complications that these patients can eventually experience. So that's our goal, is teaching and letting them know, you know, what is good and what is not good. You know, we know this now because we're nurses, but you know what? How many people out there have been really taught about numbers? You know, somebody could take a blood pressure, but it doesn't mean anything to that person unless they understand, okay, so I took my blood pressure, so how do I interpret those numbers? The same goes for someone's blood glucose. You've got to tell them what do they need to achieve? What numbers do they need to see? What numbers tell them that their blood glucose is in control? Just because they're on insulin or medications doesn't mean they're necessarily going to be under control. We've got to make sure that they're adhering to the whole kit and caboodle, meaning are they following diet? Do they monitor themselves before exercise? You know, are they taking their medications the way the way they're supposed to? You know, sometimes those syringes and those little lines that designate the exact amount of insulin, maybe these people already have visual problems and they're not seeing the lines. So there's a lot of factors that really affect whether or not these people are under good control or not. And some of it can be teaching, but other reasons can be poor technique, you know, or not really understanding, you know, when they give their insulin. You know, is it the short acting, is it the long acting, all that kind of stuff. And we're going to talk about insulins in just a little bit. And again, we've already talked about hemoglobin A1C. And that's why we continuously monitor other lab values that really give us an evidence as to has there been any damage due to the fact that this person has been a diabetic a long time and has really not been under any good control. So that's why we check albumin, urine tests for renal function, BUN, creatinine, and also, looking at the basic urinalysis. And I know we haven't gone over that because we haven't touched renal yet, but there's certain things in the urine that should not be there, and when it is, that sends us a red flag. Okay, so isn't it amazing, all of us as nurses, what we have to know in order to keep our patients healthy and to keep them from developing some very serious complications. So again, these are some of the other topics that we're going to talk about. And see, it's a lot. It's a lot for us as nurses, and it's a lot for our patients. Even the diet in itself is a lot. That's why it's very important to bring other disciplines in, to sit down with that diabetic and really talk about food planning, and bring in the person in the family who does the grocery shopping, the person who cooks the meal, so they're very aware of, what does a 2,000 calorie diet consist of? What is a carbohydrate versus a fat or a protein? Planned exercise, and really educating that person about their medications, whether or not it's a pill they take, or even insulin, or even both, and a frequent, follow-up doctor appointments. And does your patient know what they're going to feel when they become hypoglycemic versus hyperglycemic? We have to know that as nurses. You need to know right away, when you see your patient become a little lethargic, start shaking, or complain of a headache, that right away, my patient's developing hypoglycemia. I need to check their blood glucose. What are they going to do when they're sick? We get sick off and on here in life, and this will affect their blood glucose. And a lot of times we think right away, oh my God, they're not eating anything, let's not give their insulin. Well, that's the wrong thing to do, because we can't forget about what we've learned earlier about counter-regulatory hormones. And with dental and foot care, with neuropathies, either involving motor or nerve neuropathies, we can see some definite complications that can occur. So that's why all this teaching really needs to be kind of implemented, but at short intervals. We can't overwhelm a patient with all this information. I know I'm overwhelming you with diabetes, but I think people think diabetes, it's just about high blood sugar. But look, these are just a very little piece of the puzzle in regards to helping a patient maintain a acceptable level of their glucose. So let's talk about BGM, or blood glucose monitoring. This is absolutely essential, and if we're going to talk about one thing to teach our patients, this sure is one, because how can you manage blood glucose when you don't even know what the blood glucose is? How do you know if you're under control? Because not all people manifest the symptoms of hypo or hypoglycemia. And if they're not checking their blood glucose, then they're probably not checking their urine for any type of ketones. So usually that's done if that blood glucose is well over 250 or 300. And obviously with self-monitoring, checking one's glucose levels, it shows elevation with food, it documents hypoglycemia, it provides the data for a patient, healthcare provider in managing diabetes, and you want to make sure it's being done correctly. You want to have the patient and the family demonstrate blood glucose monitoring to be sure the patient is following proper technique. And that's why when they're in the hospital, that gives us an opportunity to be able to do that. And you also want to make sure that your staff, your PCNAs, are also monitoring correctly. Self-monitoring of blood glucose really does allow the person with diabetes to monitor and achieve metabolic control, and to also decrease the danger of getting to those hypoglycemic levels, okay? The American Diabetic Association recommends that all patients with diabetes be taught some method of monitoring glycemic control. And the timing of when they do monitor themselves is highly individualized because it really depends on the person's diagnosis, their general disease control, and also their physical state and really their basic lifestyle. Blood glucose monitoring is recommended 3 or more times a day for patients with type 1 using multiple insulin injections or insulin pump therapy. Obviously, postprandial glucose is often the most useful information for evaluating level of glycemic control in the type 2 diabetic patients. But we as nurses, we always check their blood glucose prior to meals, AC and HS. And remember, probably the most important times to self-monitor your blood glucose is when a person is ill or obviously pregnancy, and we're not going to get into that because this is an OB, or else when someone has manifestations of hypo or hyperglycemia, okay, when it's not very, very well controlled. Because sometimes hypoglycemia can happen and a person can be actually unaware. They should be monitoring themselves during an illness, before and after exercise, if they have problems with like gastroparesis, some of these neuropathies, if they're in the process of adjusting medications, maybe they've upped their insulin or added a second oral anti-diabetic medication, this is the time where you want to monitor your blood glucose. Evaluation of other drug therapies, even people who are considering trying to get pregnant, preconception planning, and definitely during pregnancy. And we want to make sure that if anyone has some disabilities or impairments, that particularly if they have vision problems, what's nice out there is they do have talking meters that actually give them the results of their blood glucose without even looking at a screen that could be misinterpreted. So they actually talk and say, your blood glucose is such and such. You know, there's certain goals that diabetics need to hopefully achieve when we talk about glucose levels and also hemoglobin A1C. Okay, and with that information that they get when they do monitor themselves, they can alter their diet, they can change their physical activity, and even their medications to reduce those postprandial increases and reduce their risk of complications. Because, I mean, hypoglycemia is much more serious, but with high blood glucose and the constant state of hyperglycemia, these are the people that later on are going to suffer from all those complications that we talk about or have some degree of them. Some have sensors called the continuous glucose monitoring. A lot of these patients that already have like insulin pumps will set perimeters as to, you know, when they will be alarmed as to if their blood sugars get too low or too high at a certain level, the alarm will go off. And so maybe they'll have to increase their insulin if their blood sugars are continuously high, or maybe decrease their insulin if they're suffering from at least 2 to 3 bouts of hypoglycemia a week. With self-monitoring blood glucose, usually there's a lancet device to perform a finger stick for obtaining that drop of blood. And usually there's strips, and I'm sure you're all familiar with this procedure. You've been doing it in clinicals, and but it does take proper technique to make sure that we're getting the most reliable information regarding blood sugars. So make sure that you know how to use your blood monitor you know, consistently and correctly, and read instructions carefully. And you know, there's certain factors that may affect glucose meter performance. Make sure that the strips are not outdated, that they're not exposed to air, humidity, and usually you need a sufficient amount of blood or it's not going to read that blood glucose monitoring. Okay. Sometimes, you know, when these patients, especially our type 1s, who will definitely be on insulin, remember, once a diabetic, always a diabetic. So injecting insulin every day doesn't mean that you're cured of diabetes because you're bringing in an exogenous form of insulin. No, that's not the case. It's just a way and a means to control blood sugar. People who are unable to control glucose levels with oral anti-diabetic drugs and or diet may need to be put on insulin, and sometimes the physical stress of infection surgery or even people taking corticosteroids may need to be put on insulin. Obviously, patients who develop gestational diabetes during their pregnancies, or even people that develop these emergencies called DKA or HHS. Even our patients who may be not able to take oral medications, maybe they've had a very complex surgery and have to be on perennial infusions or TPN because of the high amount of glucose and protein that are given. These patients might need also to be put on insulin to control blood glucose levels.